Okay, we'll be starting our multidisciplinary and specialty management session. I'd like to introduce Connie Wolford, who's going to go over the role of the healthcare provider. Connie is a nurse practitioner here at Stanford University Medical Center. She joined the neuromuscular team in 2010 and has played a primary role of managing multidisciplinary care for our neuromuscular patients here at Stanford.
Thank you, Sally, and thanks to all of you for joining us on this Saturday. I'm happy to talk to you today about the role of the healthcare provider in working with patients with bulbar weakness, specifically neuromuscular. And I believe our slides are working, but what a couple of amazing talks this morning. Sarah, Jody, and Miranda, you guys did such a great job. You've actually made my task very, very easy. The role of healthcare provider is obviously early referral to the specialists. And I'm done. I have a few slides that I will present. So I know that this is, a mixed audience. We have a number of speech therapists in the audience, and I'll initially speak to you guys. You see patients with many different types with dysarthria, dysphagia, dysphonia, related to many different disease states and injuries. What you may not see what you see probably less commonly is bulbar weakness related to neuromuscular disorders. But bulbar weakness is actually very, very common in the neuromuscular population. And this slide just is certainly not inclusive, but it gives you just a few categories in which we see bulbar weakness in the neuromuscular population. Why is this important? It's important because it really does change your goals of therapy, right? With the exception of maybe the neuromuscular junction disorders, most of our neuromuscular disorders result in progressive weakness, and many of them, the majority of them, these disorders have no treatments or cures. So it will make a difference in how you set up your goals of therapy. Okay, so what's the role of the provider then? I would say next slide, please. Number one, and we had a question from the virtual audience earlier from, it sounds like a primary care provider, of where do I go first? Do I refer when I'm not clear on what the diagnosis is? The first thing that the provider, either primary or neurologist, is really to get the correct diagnosis. We can have dysphagia, dysarthria, dysphonia from a variety of causes, obviously. And we want to discern if this is something that is a reversible cause or something that we might anticipate rehabilitation from. For example, a stroke or an esophageal stricture, maybe a medication-induced dysphagia from antipsychotic meds, a variety of different things. Is this a stable or reversible disease that we might anticipate rehabilitation on? Or is this a progressive disease for which we know we have no cure or treatment? If it's the progressive disease, the goal might be compensation strategies to reduce the risk of aspiration and improve quality of life. With the current disease-modifying therapies in neuromuscular disease, we might also have the ability to improve function in those. And then assessing progression to guide our therapies versus kind of the stable or reversible disease with an expectation of rehab, where the rehab strategies would really be to reduce the risk of aspiration and improve function. And I think a stroke patient's a great example of that. And assess response to therapy and guide further therapies. So bulbar weakness, prevalence in neuromuscular disease, as I said, is quite common. We see it in anywhere from 35 to 80% of our patients. It's an equal number really in pediatric and adult patients. And presentations typically with dysphagia, dysarthria, dysphonia, sialorrhea, and prolonged eating. But this can also lead to poor nutrition and weight loss and aspiration pneumonia, which are really very critical prognostic factors in the outcomes for the neuromuscular patients. Something that we also see with these bulbar weakness is low self-esteem, social isolation, and depression. And we haven't talked a whole lot about that, but this is just another example of why early referral is important and referral to the appropriate services is important. So I have on here early referral to SLP and registered dietitian, but also social work and psychology or psychiatry if needed. So dysarthria, I would say that neurologists are very good at identifying kind of some of the early physical signs of articulation problems. They can clearly identify weakness, wasting, tongue fasciculations, things like that, tremor, abnormal reflexes. But what they're not as good at doing is identifying those subtle signs of articulation problems through some of the speech subsets that we've talked about earlier. Respiration, phonation, articulation, resonance, and prosody. Again, very important to have early referral to SLP to correctly identify exactly what the deficit is, begin education for the patient and family. If it's a disorder that would require perhaps voice banking, this is something that takes some time. The patient may have several sessions for voice banking, depending on how many phrases they want to capture. Voice banking is not covered by insurance, and they may need to work out the finances of this endeavor. So the earlier, the better, really. And then early adoption of the ACC equipment, if that is an option for them. Identifying and assessing dysphagia for the primary doctor or the healthcare provider, really leave it to the professionals. We've talked today about a lot of different assessment tools, and yesterday as well. We have some quick, easy bedside clinic tests that we can do. We have invasive tests. We have imaging tests. But I think our takeaway should be if you don't have expertise in these studies, they really shouldn't be performed by the healthcare provider. Some of the disadvantages of these studies are really reliability. And this can happen with any of even the bedside studies. You're getting a snapshot in time, which we've all seen that. When patients are getting even a video swallow, they really are they're getting their best swallow. They're positioned correctly. And it doesn't necessarily represent a real life swallow where they are probably slumped over in their wheelchair. They're tired from the day. Maybe they, want to go out and play with a friend or something, so they're eating quickly. And the video screens also don't really take into account factors like fatigability and ventilation. Comfort, besides, Miranda and Jody did a great job of describing this in the last talk. It can be uncomfortable to do these bedside studies. Certainly invasive studies can be uncomfortable and burdensome for the families. There are risks involved. Assessments involving large volumes of liquids may put the patient at risk of choking or aspiration. Radiation may be a risk, a small consideration. And then accessibility, even though the VFSS is considered the gold standard, it is an expensive study and it requires qualified staff and very specific equipment that's not readily available in all workplaces. So that brings us to some of the self-reported outcome measures that have been discussed earlier today and at length yesterday. As was mentioned earlier, yesterday was kind of a working group to come up with some other really clearly defined and accessible patient-reported outcome measures. And hopefully that will be one that we use in the future, the IBAT. But again, these have limitations, and certainly the healthcare provider is not the expert in how to administer these. So this slide really didn't turn out the way I wanted it to. So I apologize for that. It was actually going to be funny, but I want to talk about a special consideration for dysphagia in the ALS population. So we know that about 30% of ALS patients will present with bulbar ALS. So those early symptoms will be, dysphagia, dysarthria, dysphonia, sialorrhea, and that's how they identify what's going on with them. But ultimately, through the course of the disease, most patients with ALS will experience bulbar weakness. And then Briani and associates really did a deep dive into radiographic analysis of folks with motor neuron disease, and found that bulbar weakness is really present in patients with ALS even before they had any perceived weakness. So we know that ALS is a devastating disease. There is no cure. It's progressive. We know that almost every patient's going to have bulbar weakness at some point. So what do we gain from our assessments then? How does it change our course of treatment? And you can't really see this cartoon very well, but he's obviously got an arrow in his head, and the physician's saying, well, offhand, I'd say you're suffering from an arrow through the head, but just to play it safe, I'm going to order a bunch of tests. It's probably not necessary for the ALS patient, right? I mean, we know what the course is going to be, so let's not put the patient at risk. And I think the question to always ask is, how is this study going to alter my treatment course? How is this going to alter anything really for the patient? It gives us information that we pretty much already know. Now, the exception to that would be, of course, and that's where research was supposed to come in, on top of that, is for research. And many ALS patients want to contribute to research. But having assessment tools that are validated, that are, can be used to further our knowledge and understanding of this devastating disease, but can also be used in clinical trials to get new therapies approved, would be kind of the reason that you would continue to go on and do assessments for these folks. I only have a couple of minutes, unfortunately. But I wanted to talk a little bit about the PEG intervention. This is another area where the healthcare provider can interact with the speech therapist, dietitian, pulmonologist, actually, and the patient and family. The American Academy of Neurology does recommend a PEG insertion in the ALS population after the patient's lost greater than 10% of their body weight. And then AAN and the European societies, their guidelines recommend for management of ALS patients, PEG placement before the occurrence of FVC less than or equal to 50%. We're not here to debate the efficacy of a PEG in an ALS patient, but we do know that PEG may prolong survival because it can increase or reduce weight loss, I'll say. And PEG has been found certainly to yield benefit in other neuromuscular diseases. So coordinating with the speech therapist early and the dietitian is important. We know that it does take a long time for ALS patients and probably all diagnoses to kind of wrap their brains around the PEG intervention. Gaspar and associates looked at a very small cohort of ALS patients, and they kind of found that the median time to PEG was 12 months from diagnosis and 4 months after the first reported bulbar signs. But then Sun and his group took a look at a larger cohort of ALS patients and found a PEG insertion was about 30 months after the first symptoms. For symptom onset, and 22 months after diagnosis, with the median delay of about 8 months from the time it was suggested. And if you work with ALS patients, you know that 8 months is huge. There's a lot of decline that's going to take place in that. And they did, in fact, find that a significant drops in weight, the ALS, FRS scores, and BMI during that time in waiting. What are the factors that delay PEG insertion? There are many. I just told you about one, that patients have a hard time kind of grasping that concept. Patients tend to delay PEG until they next slide, please. Until they themselves are experiencing choking. They oftentimes feel that accepting a PEG is a loss of their autonomy in a disease where they've already lost so much autonomy. Sometimes they're worried that there will be a real caregiver burden if their loved one has to begin feeding them. Some patients feel that a PEG insertion really is a means of extending their life, and they're not really sure that that's what they want to do with a disease like this. Lack of awareness of the benefits. I often try to explain to my patients that, a PEG doesn't have to be all or nothing. It can be a way to really improve your quality of life, and the sooner you have it placed, the better. I had one patient that I always refer to that told me that he took everything through his feeding tube, medications, the bulk of his calories, and the only thing he took by mouth was red wine and chocolate. And I think that's just a great testament to, this is your quality of life, and we acknowledge that that's really important to you. But these are the benefits that you can get from a feeding tube. And I think sometimes providers don't give a full picture of that. So there's hesitation by healthcare providers to really discuss the PEG too early. There really isn't a too early. And then sometimes folks are awaiting NIV because it is recommended that non-invasive ventilation be used before, during, and after to improve the outcomes. So the role of the healthcare provider here really is to use that trusting relationship that you have with the patient and the rapport you've built with the patient and family to suggest interventions and suggest them early on. Introduce the topic early, restate it as needed, and make sure the patient and family are able to kind of repeat back to you why this is an intervention that's important. I often tell patients with ALS that my job is really to give them all of the information they need so that they can make an informed decision. And then once they make that decision with their family members, you accept that and work with them. I'm over my time, but I am going to just go on for a few more minutes here and talk about the next role that I see of the healthcare provider, which is really documentation. Everything is expensive. Insurance, we've talked about a bit yesterday, really will do their best to kind of cut costs. So one of the roles of the healthcare provider is to document things appropriately so that we can get therapies and interventions covered. This is just let's see, I think I've got the CMS, the CMS guidelines or medical necessity for enteral feeding, for example. So PEG insertion's not usually that difficult to get covered. Enteral feeds are difficult to get covered. You might encounter an ALS patient who somebody ordered a feeding a video swallow screen on, who somehow passed the video swallow screen, even though in their normal setting they're aspirating all the time. That's a situation where the insurance wouldn't pay for enteral feeds, right? So another reason not to do those studies. But anyway, medical necessity in order to show that, or even for ACC equipment, in order to show the medical necessity, it really is important that the healthcare provider document that appropriately. And in our MDA center, we use some smart phrases that you can just drop into your notes. X has progressive dysphagia in the setting of ALS. X is at high risk of aspiration and weight loss. X cannot meet daily caloric requirements with oral intake alone. Need for PEG tube with enteral formula feeding is medically necessary for his or her lifetime. And that really kind of says exactly what it meets their requirements. And same with the ACC. X presents with progressive severe dysarthria in the setting of ALS, significantly limiting their ability to communicate verbally. Evaluation results demonstrate significant difficulties with word retrieval, sentence formulation, articulation, rendering natural speech insufficient for functional communication. A speech-generating device with a robust vocabulary, picture-based access, and text-to-speech output is medically necessary to enable X to express basic needs, participate in social interactions, and maintain quality of life. So that's why you have a smart phrase, because that's a lot of words. But those are the things that will actually meet criteria for payment. So just to recap, I'm sorry, there's one more slide here. The other role of the healthcare providers, obviously to manage symptoms, and this is primarily seen, I think, with sialorrhea. Three of the things that we do use: anticholinergic medications, which can lose effectiveness over time, but luckily there are many of them to try. Botox injections into the parotid and submandibular salivary glands is not reversible, but can be repeated as needed. But again, these sometimes lose effectiveness over time. And then radiation. So either the external beam radiation that kind of broadly radiates the major and the minor salivary glands, or an intensity modulated radiation therapy, which is very selective in irradiating bilateral submandibular and parotid glands, but because it's selective, it doesn't cause excessive drying. So you're sparing some of the glands. And Dr. Mayer is going to talk more about symptom management for sialorrhea next. So to wrap it up, the role of the healthcare provider with the patient with bulbar weakness really is as a facilitator. First, get the correct diagnosis so we know what path the patient is going down, and that can guide therapies. Early referral to speech therapist, dietitian, respiratory therapist, and pulmonologist. Facilitate the testing as needed. Introduce interventions and kind of set realistic expectations early. And document the medical necessity of such interventions and symptom management. That's it for me, but what questions do you have?
Are there adaptations to clinic charges that can account for the increased length of appointments caused by impaired communication?
Yeah, that's a great question. And people probably are forgetting to do that, but there are actual, people charge differently for their encounters. Sometimes it's time-based, and there are additional charges you can place for complex patients that require additional care. So yeah, that would be a thing to do for those that require lots of additional time. And then just kind of remembering when they're scheduled that this is going to be, versus instead of a 2-hour appointment, this is probably going to be a 3-hour appointment. Yeah.
Thank you.